Hello and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Thanks for joining us. Today's program is titled Diabetes and Multivessel Coronary Disease, and our distinguished guest is Bob Harrington, Professor of Medicine here at Duke. Bob, thanks for joining us.
Sunil, thanks for having me.
So Bob, we had an interesting situation in the CCU last week where we admitted a 74-year-old lady with a long-standing history of insulin-requiring diabetes. Her GRACE risk score indicated that she was moderate to high risk when she came in with non-ST segment elevation ACS. So we elected to proceed with invasive risk stratification. And it turned out that she had two-vessel coronary disease. One vessel involved was the LAD.
Proximal LAD?
It was proximal LAD, and she had mild to moderate LV dysfunction, somewhere around 40%. And the discussion that we had was, is this lady better served with percutaneous approaches, or should she undergo bypass surgery? And if we choose the percutaneous route, first of all, how should we present those options to her? And if we chose the percutaneous route, is complete revascularization going to be achievable, and is that the goal? So what can you tell us about those types of things?
So do you want to, why don't I walk through some of this, because I think it'll answer some of the questions, and maybe we can stop along the way and address some of the specific issues relevant to this patient, because she does represent the common, I'll say the common patient with diabetes. So what I'd like to do, Sunil, is go through three topics. First off is let's think about the general considerations and how we decide upon revascularization in patients with coronary disease. Then ask the question, as that sets the framework, are the revascularization decisions different if you have diabetes? And then we'll just sort of look to the future about what are the kind of things that people are studying in this arena, and maybe this will help answer your question. So first, let's talk about the general considerations. This is a slide that I use all the time. I like to make the point that everything we do in patients with coronary disease, including your CCU patient, you should ask the three questions. What you're going to do, is it going to make them live longer? Is it going to make them feel better? And from a societal perspective, can all this be done in a cost-effective manner? And I think that every time you offer therapy, you ought to go through those three things. And if your answer to all of those is no, you should think real hard about what you're offering. And I think in the diabetic patient, we actually have a fair bit of data to begin to understand what should we be offering in terms of revascularization. Now, the first thing in thinking about your patient with proximal LAD disease is to risk stratify them on the basis of anatomy. We can come back. You've already risk stratified her clinically using the GRACE score in the setting of her acute coronary syndrome. But once we know the coronary anatomy, there's a lot of other ways to risk stratify them. And we do know that the more coronary disease you have and the more complex coronary disease you have, the higher risk you are. So, for example, in this work by David Kong, Peter Smith, Bob Jones, a number of people at Duke over the years, they've established the so-called coronary artery disease index. And it's all based on angiographic findings, and it's pretty straightforward. If you have no epicardial stenosis, which are felt to be, quote, significant, end quote, meaning stenosis greater than or equal to 50%, your relative risk of cardiac death is pretty low. But if you go up to the other extreme, 95% left main disease, your chance of a cardiac death is actually quite high. And then there's everything in between. And the key question that I asked you is, if you look on the slide here, is once you cross over into the proximal LAD territory, you start to have a higher risk. Now, the syntax investigators took that a step further. They not only looked at the burden of disease, as we've described it, 1, 2, 3 vessel disease, left main, not left main, 50s, 75, 95s, but they've also begun to look at the complexity of the disease, as you know. And they look at, is this a total occlusion? Does it involve bifurcation? Are they aortoosteo lesions? Are they long lesions, heavily calcified? And I think what this is helpful for is it begins to do what we all do in the cath lab naturally anyways, which is we assign a level of complexity to the anatomy. Well, why is all of this important? All of this is important because it seems that the higher risk you are, the more likely that the more invasive strategies are going to benefit you. So the more high risk you are, PCI seems to be better than medical therapy, and the more high risk you are, CABG seems to be better than PCI in the most high-risk subsets. So you've seen this paper by Mark Latke in the Stanford group who published this in the Lancet last year, looking at all of the published data, the randomized trials that looked at bypass surgery versus PCI for multivessel disease, 10 randomized trials. When you think about it, an operation that's done hundreds of thousands of times a year in the 10 trials are about a few thousand patients. I think it's 6,000 or 7,000 patients. Rather fairly staggering that this is the body of the evidence. Nonetheless, I mean, I think that this table in the paper is the key finding. That if you're looking at death or myocardial infarction as a combination, as a composite endpoint, the two strategies don't appear much different from one another. But where in all patients. But where the real advantage of bypass surgery comes is that you clearly will need less done to you. So if you go to our category of does it make the patient feel better, as a subtext to that, I include the notion that does the patient avoid unpleasant experiences? One of those unpleasant experiences is coming back to have something else done to them. But I think this offers you, Sunil, also some sense of being able, you said, what do you tell your patient? You can tell patients, look, as best we can tell for this type of disease, we don't believe that there is a survival benefit for this operation, or we don't believe you're less likely to have a heart attack. But you're going to undergo a big operation, and we'll talk about how big it is. And you might end up with less repeat procedures. And in somebody's value system, they might be willing to choose the big operation to avoid the repeat procedures. In other people's value system, they say, no, 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 I don't want that big upfront procedure. And I think it's data like this that gives us the opportunity to actually have those informed discussions. You know, Latke and his colleagues, they looked at all sorts of subgroups. Not a whole lot stood out as being different. It's interesting, if you look at the overall effect, the point estimate seems to marginally favor bypass surgery, but not statistically significant. And all of the subgroups, sort of the point estimates do line up on the side favoring bypass surgery. But let's look at three subgroups in particular: age, gender, and diabetes. And let's specifically look at the last one because that's the topic of the conversation with your patient. This is 5-year mortality, diabetes versus no diabetes. Now, all the caveats, diabetes is largely defined by the investigator in the particular clinical trial. Not a lot of details given, but about a 7.5% absolute mortality difference favoring CABG over PCI, relative risk of about 30% reduced with CABG over PCI in the diabetic patients. It's pretty striking.
Now, Bob, in this study, did they account for, these are randomized trials, not registry
This is the
data.
10 randomized trials. This is the 10 randomized trials that have been done. Mark did this as a collaborative project, was able to get the individual patient data, was able to do some actually fairly sophisticated analyses to adjust for some of the differences amongst the trials. I would say, Sunil, in the absence of a mega trial, a truly large, 5 to 10,000 patient trial where we follow the patients for 5 to 7 years, this is the best data we have.
So these are patients in whom, in all of these trials, there's a surgeon and an interventionalist who come to a consensus saying this patient can be treated either way.
We're comfortable randomizing this patient. Somebody's made the decision that we're comfortably randomizing. Now, I think you're getting at one of the criticisms of these kind of trials, that there's always the notion that, well, the interventionalists pick off the ones that they prefer to do. The surgeons pick off the ones that they prefer to do. Nonetheless, this is the best we have, and this is the randomized data.
Right. And as you said, these are patients who could have been treated either way and were randomly assigned. So,
and the diabetes does seem to be a potent predictor of patients doing better with bypass surgery or PCI. Now, you start to ask the question, I thought you were going to ask the question, well, if they go to the cath lab, what about drug-eluting stents? And does that, confer some additional benefit? Well, as you know, in all the DES versus BMS trials, we don't see a survival advantage. We don't see a lessening of myocardial infarction advantage. What we largely see is a repeat revascularization advantage. And maybe that would help. Well, a trial's been done. As you know, the syntax investigators did this trial. They asked the question in patients with complex disease, PCI, largely utilizing drug-eluting stents against bypass surgery, published in the New England Journal just last year, 2009. And here's the punchline from the abstract. CABG remains the standard of care for patients with 3-vessel or left main coronary disease, since it's associated with less of the combined endpoint, interestingly, at a year. So let's look at the individual data. No difference in death, although the death rate is relatively low and it's unlikely that there's enough power here to determine a difference between the two groups. No difference in the composite of death, stroke, or MI, but look at where it starts looking different is when you add in repeat revascularization. So even using the best contemporary PCI strategy, drug-eluting stent, bypass surgery in this randomized trial appears better. Now, this is the 1-year outcome. There's still more follow-up to come from the Syntax trial. But I think that this is consistent with it's certainly no different than the LACI data. And I think it begins to tell us that, well, in our highest risk patients, and I'll show you some of the data that suggest maybe that you can further risk stratify your patient and begin to understand, is there an advantage of bypass over PCI?
Now, this trial, when it came out, it was interesting seeing the reactions of different factions, if you will.
The stakeholders had different views, didn't they?
Yeah, exactly. Where the interventionalists pointed to the stroke risk data.
Being higher in
the bypass surgery arm. What are your thoughts on that?
That gets back to my original question about asking your patients about their value system. And I think it's really important as we begin to have more and more data, what we really need to begin to do is offer patients personalized choices. Harlan Krumholz had a terrific perspective piece, I think it was in JAMA in the last couple of weeks, dealing with this notion of personalized informed consent, where you actually are able to go through in much more detail with patients. What are their individual risks based on data like this? You know, John Spertus down at Mid-America has created models so that if you're going to undergo PCI, he can, for your anatomy and your clinical characteristics, they actually put in their consent form what your risk of death, myocardial infarction, restenosis is with all the technologies that they know. And then that allows you to make a more informed decision. Some patients might trade off some of these things.
So in that context, this is a little bit afield from what we're talking about, but it's somewhat related. Is there an excuse then for us not to use the information that we have available when we're getting informed consent or talking to patients about these types of data? Shouldn't we be more specific about what we're talking about?
I think that we have enough information now, Sunil, that we probably should. It's awfully hard to do, as you know, in the context of busy clinical practice. But if you think about it years ago, you know, Dr. Stead, when the data bank was formed, had this notion that you could make better decisions if you had access to the aggregated data. Mm-hmm. Here we are 40 years later, and you know, guys like Krumholz, guys like Spertus, guys like Eric Peterson are encouraging use of that data for this sort of individual decision making, but I don't think we use it enough. I don't think we use it enough. Let me ask you, when you go see a patient for PCI, what statistics do you quote? Do you quote the literature statistics? Do you quote the Duke statistics? Or do you quote your own personal statistics?
Right. I think I do probably what everybody else does, which is you quote the same statistics that you were told to quote when you learned how to consent people. And you said the risk of anything catastrophic happening is 1 in 10,000. And those are the data that you present to everybody. What's interesting, though, and this may be relevant to the diabetic patient, is that when you're faced with a procedure or a patient in whom you're a little worried about the outcomes, we do tend to inflate that risk a little bit, don't we?
And we tend to give them a lot more specifics than we might otherwise, right?
Exactly, yeah.
So it is an interesting question, and we probably are not doing justice to the data that we have available to us. And, you know, at our own place, we're not giving our patients my statistics when I go consent them, nor I suspect you're giving yours. You know, I think we do think about what the outcomes are in the Duke lab. But I don't think we use it on a real-time accrual basis. Right. This is where I was getting at with your patient. So you risk stratified your patient on the basis of her clinical characteristics to get a GRACE score, which I think you said she was moderate to high risk. Yeah. Well, you know, you can risk stratify her angiographically now using the Syntax score. And I think that the Syntax score findings from the Syntax trial are very consistent with what we know about medicine in general, that the higher risk you are, the more likely you are to benefit preferentially from high-risk therapies. So if you look at the Syntax score and you have a high Syntax score, look at the advantage of bypass surgery or PCI. It certainly appears a lot bigger. It's a 13% absolute difference, you know, more than a 50% relative risk reduction in the primary composite endpoint. So none of this is definitive, but it's certainly consistent with the Latke data. It's consistent with a lot of other things we know in medicine. It would seem that, one of the things you might be able to do with your patient is provide her syntax risk stratification, her syntax score, and then help her make some decisions. Now, I said I was going to come back to this notion that there is no free lunch with cabbage, and I think that that's shown here. As you know, we, led by John Alexander and a group of surgeons, did a randomized trial looking at an E2F decoy to prevent vein graft attrition. One of the major problems, as you know, with bypass surgery is its durability. Well, I put this up here not so much to think about the edifoligide issues, but more just the striking thing about vein graft failure and when you look for it. So these patients were all cathed at 15 months on average after their bypass operation. Look at 45% of patients have lost a graft by 15 months. 30% of the grafts are gone. That's astonishing. That's not what we quote, is it?
No, it's not. In fact,
we quote a 5 to 7 year median, don't we?
Right. And it's 3 to 4 times higher than what we would see for in-stent restenosis with drug-eluting stents.
And this, though, is probably the best contemporary data because we systematically cast, several thousand patients following their first bypass operation. On average, patients had 2 veins in an IMA, and this is the angiographic failure rate.
One question that I've heard asked before when comparing cabbage versus PCI, particularly in registry settings, is there perhaps a difference in the presentation of the patient who presents with in-stent restenosis, for example, versus someone who may have an occluded graft? For example, at the time of surgery, there may be a lot of vessels that are bypassed which may not, in fact, be symptomatic for the patient. So if the patient has vein graft failure, they may be asymptomatic, whereas the repeat revascularization may be inflated by the
I think that's a fair criticism that gets to the issues of the different types of what I'll call the mechanistic underpinning of the revascularization benefit. By going around things and by putting in multiple grafts, one might even argue that you protect the heart. If you lose, an anterolateral, but you have a nice IMA to the LAD and you have collateral blood flow there, a lot different than if you lose the stent that was sitting in your anterolateral.
Right.
So, I think that that's a legitimate question, but it also might speak to the strength of bypass as an operation.
That's right, because half the time during PCI we may not be treating the right vessel to begin.
Yeah, and I'd be what we haven't done is systematically cath people 24 hours after bypass surgery. I wonder how many of these grafts don't even survive the OR. Right. You put them in poor flow, small distal vessel. Sure. You have a 10-12% infarction rate around the time of bypass surgery. How many of that is grafts that went down? So certainly other things to consider in terms of your weighing of values. The things that sometimes don't get mentioned in quite some detail. The sternotomy, the risk to it, the pain, mediastinitis, the problems with neurologic injury, including subtle neurologic injuries, cognitive defects that accompany particularly the pump run, renal failure, post-pericardotomy. I think there's a lot of other things for bypass that we need to think about. All right, so now that's the general framework for bypass surgery. Are revascularization treatment decisions different for diabetics? Critical question because, as with your patients, there's a lot of diabetes out there. These are data from from ACTION, just pointing out in the acute coronary syndrome, be it ST elevation or non-ST elevation, somewhere between a quarter and a third of our patients have diabetes. And the diabetics, as you know, more heart failure, more prior revascularization, older patients. So a lot of issues with diabetes. A lot of mechanistic reasons to believe that the diabetic patient is going to be more challenged. First off, diabetes travels with other comorbid diseases. There may be biologic reasons that accelerates both atherosclerosis as well as the restenosis process. And no matter what data set you look in patients with coronary disease, diabetics appear to fare worse than non-diabetics. Old data, this is from the mid-1990s, diabetes versus no diabetes, simple analysis at long-term after angioplasty, a doubling of the mortality risk. STS, no diabetes, diabetes, oral medication, insulin medications, there's a risk gradient for in the STS database. So diabetics do appear to fare worse than our patients without diabetes. One of the longest follow-ups we have now from Barry 2D, again, diabetes, no diabetes, patients that fare worse, diabetes who gets revascularized against the non-diabetics. So there's a consistency here that, yeah, diabetics do appear different in that they appear to fare worse overall. The second part of the question, though, is do they fare worse with one strategy over the other? Let's go back to the Latke paper. The Latke paper would suggest that, in fact, one of the real advantages to bypass surgery, specifically in the diabetic population, look at these survival curves of 4 groups, CABG or PCI with and without diabetes, and look at the group that fares the worst. The group that fares the worst are PCI with diabetics, in diabetics. It suggests, if you look in the non-diabetics, CABG and PCI actually appear fairly comparable to one another. So it raises questions in your patient. Once you have diabetes, maybe the default should be going towards bypass surgery, particularly if they have a high syntax score. Now, there's other things, though, to keep in mind with diabetics, and particularly, how old did you say your patient was?
74.
So she's 74. If we look at the STS models for I think actually this is the HA models for perioperative risk. You get additional points for being older. So 70 to 79, you get a certain number of points. But look what else you get points for. You get points for stroke and mediastinitis. And so utilizing scores like this where you can understand, yes, you have a mortality risk, but you also have a stroke risk, and you also have an infection risk if you undergo the bypass operation. I think that allows you to have a more informed decision with your patient. Now, I'm going to get into the PCI question that you asked. If you're going to do PCI, does it make a difference if you completely revascularize them? I would say, Sunil, it probably does, in particular in a patient with complex multivessel disease. And we're all, I'll say, somewhat guilty of this. You see the nice, juicy, what appears to be the infarct lesion, you treat that, and you want to leave the rest of it alone. Well, if you look in this non-randomized analysis, complete revascularization versus incomplete from the New York State Registry, there does appear to be a survival advantage conferred by complete revascularization. Now, it's not randomized, but it's suggestive. These are the predictors of incomplete versus complete revascularization, diabetes being a key one. And we all know this, right? Diabetes, you see diffuse disease, long disease, bifurcation disease, the kind of things that might make things a little more difficult to tackle. So that's the general framework of who benefits from revascularization. It appears higher risk, more benefit from the more aggressive strategies. Diabetes appears to really elevate your risk, and it appears as though there's consistency of that message that if you're a diabetic, probably the more aggressive strategies benefit you. So if you can document that you have a high syntax score, for example, you might push that patient in the setting of bypass surgery versus PCI. Let's finish up with the trials, and maybe we can have some more conversation. Barry 2D, important piece of information, as you know, published last year, 2x2 factorial design in patients with stable coronary disease. So your patient has unstable coronary disease, but stable coronary disease and diabetes. The 2x2 design with insulin providing, insulin sensitizing, and then revascularization of choice, which is not the same as PCI or CABG. The physicians got to choose which one they got. Overall, as you know, there was no survival advantage conferred of revascularization versus medical therapy in this population. But the Barry investigators do point out, again, that in the highest risk group of patients, that there does appear to be some advantage of bypass surgery over medical therapy. Now, this is not randomized, as you know. This is one of the cohorts. Randomization is stratified in that cohort, but I don't know. This seems to me to be a hypothesis that's consistent with other things we know, but is far from definitive. There is a trial still underway, as you know, being run by Valentin Fuster and Mike Farku, patients with diabetes, multivessel disease, randomizing them to PCI with DES versus bypass surgery. So we will get, there's no medical therapy arm here, but if you believe that diabetes confers a level of risk that bypass surgery might be better overall, now we'll be able to randomize bypass versus PCI.
You know, Bob, what strikes me about these trials is that they're incredibly important questions, but they take a long time to complete. And one of the issues, I think, is the way we approach patients to consent them for trials. The traditional approach is to say, we know that you have these blockages, and we don't know which approach is better. And frequently what the patients will say is, so let me get this straight. You don't know which one's better. One of them you cut my chest open, and the other one I can go home tomorrow. I think I'll take the stents.
Yeah.
What's your advice? How do we approach patients to randomize them in trials like this?
Well, let me answer the first comment you made before I answer the question. You said these trials take an awfully long time. They take an awfully long time in part because we've dragged our feet. I mean, think about this. We've been doing bypass surgery for what, since the late 60s, early 70s. We have about 7,000 randomized patients in the bypass surgery versus PCI literature. We're doing hundreds of thousands of these operations around the world a year. I would say that why haven't we answered the question? Yeah, they do take 2, 3, 4, 5 years of follow-up, and they are hard to do, but come on. If we as a society really want to, if we insisted that you had to answer these questions or you wouldn't get paid for it, don't you think we'd have answered the question?
And that day may be coming.
and you know,
right.
That day should be coming.
Yeah.
Because we ought to be able to say to our patients that, you know, now that gets me to the second question. That ought to be able to set up the framework of the conversation. Well, let me talk about why one might be worth opening the chest, doing all these different things, versus, you know, oh, you can go home tomorrow. Mm-hmm. And let's have an informed discussion about early hazard versus late benefit and really be able to go through the data. But you have to have data that helps you be a little more certain to make those pronouncements.
Right. One approach that I think at least I've seen be successful is to really be honest with patients and say, listen, the standard of care here is to get bypass surgery. We think that modern PCI techniques may be beneficial in order to have a chance at getting that. Which actually brings me to another question, both for clinical trial purposes and especially in the clinical setting. The bottom line is the gatekeeper for the decision, as it's presented, is you and me. I mean, we do the diagnostic cath. We give the patient an overall view of what the risks and benefits are while they're on the table. Do you think that's the right approach? Should we be taking the patient off the table and maybe coming to a committee with a surgeon and the patient's cardiologist, the patient's family to try and decide these?
Remember in the early days of, well, you don't remember in the early days of PCI, but it used to be like that, and we always did PCI the next day, and we frequently at the end of the day looked at all the films in consultation with both the patient's primary cardiologist as well as frequently with the surgeons. Right. And remember, in the balloon days, because you had to have an operating room on backup, there was a lot more upfront exchange about what you were doing. As things got pretty good in the cath lab, we got away from that. I think what's actually pushed us back to that are a series of things, but maybe most notably the challenges around drug-eluting stenting in long-term dual antiplatelet therapy. I think that's actually forced us to revisit this notion of having more conversation, really thinking through the issues. The surgeons say we don't have enough of these conversations, and the surgeons have sort of, they're like the person who quit smoking and is now an advocate, for almost a zealot for getting other people to stop smoking. Well, the surgeons are now zealots for having those conversations. They weren't necessarily zealots years ago, but now they're certainly, we got to have those conversations. Right. But I think there is value, all kidding aside, I think there is value to this notion. It's been called the heart team, mm-hmm. the cardiac team, where a team of physicians and other providers come together to say, hey, these are the options. Let's talk about what's important to you. Let's talk about what the data that's available, and let's work with you to come up with the best choice that fits your lifestyle, what you hope to get out of this, et cetera. And I'm optimistic that you see more and more of that. And I think the drug-eluting stent issues drove some of that conversation. I think trials like Courage mm-hmm. have driven some of that conversation. We're doing a trial now called Ischemia, or we hope to be doing a trial. It's been submitted for grant review. Judy Hockman, Dave Marin are the overall leaders, but Greg Stone, well-known interventionalist, is leading the revascularization part of the trial. And we have recommended that each of the sites have a heart team mm-hmm. that go through these issues with the patient about what is important, what can they expect, what might they benefit from.
And after all, that's what the trials mandate, right?
That's
if you're
all
going to participate in the Freedom
right.
trial, for example, you have to have a team that's comprised of the surgeon as well as the interventionalist.
Probably a good idea.
Yeah, absolutely.
Let me try to finish up for you. Appropriate use. So now the question is, what do we offer the diabetics today? And I think if you look at things like the appropriate use criteria that comes out of the ACC, AHA, and a variety of other groups, this happens to be the one led by our colleague Manish Patel for coronary revascularization. It's the same fundamentals that we've thought about all along apply to the diabetic patient. So what do I mean by that? CABG versus PCI, the more advanced disease, two-vessel disease, including the proximal LAD. CABG is appropriate, so is PCI. It comes to the judgment of your patient. But look, Sunil, as you quickly go to three-vessel disease. CABG felt to be appropriate. PCI felt to be inappropriate, or uncertain, rather. If you go into isolated left main disease, now you're pushing towards bypass, more inappropriate for PCI. Doesn't mean you shouldn't do it. Just means that for the routine consideration, it should not be your default position. And I think that these data fit with what we've talked about, from the LACI data, from the syntax data. It sort of all fits together. So let me close with this, and maybe we can talk about your patient. We didn't even mention medical therapy, but I put this up there as the first line, that everybody deserves intensive medical therapy. I think Courage showed us that. Coronary revasc is an important issue for patients who have CAD, and there is a fundamental tenet that overall benefit increases with patient risk, and CABG does seem to be preferred over PCI in more advanced forms of coronary disease. Diabetes is clearly associated with worse outcomes, but the fundamentals don't change. Diabetes just moves you quicker to a high-risk status, but if you're diabetic and you're high risk anatomically, you need bypass surgery.
So that's terrific. I mean, I'll tell you what we decided with our patient. But given her history of diabetes, given the location of the coronary disease and her mild LV dysfunction, we felt that CABG actually offered her a survival benefit. And that leads me to maybe the final discussion point here is, we've seen repeatedly now that the higher risk patients are, the more benefit they get. From something like PCI versus CABG, when we're talking about very, very high risk patients, do you foresee that sort of driving the formation of PCI and CABG centers? Certainly, you wouldn't want the operator who's doing 30 cases a year or 25 cases a year doing a high-risk PCI. That's probably better done in a high-volume setting, don't you think?
Well, this has become really almost a U.S.-specific issue. If you go to the rest of the world, that is what they have. They have referral centers, and patients get, you might have relatively routine PCI in one type of center, but if you're going to have complex PCI, bifurcation disease, current total occlusions, ST elevation MI, PCI, they get pushed into to more specialized centers. That would be the ideal world. The challenge, though, in the U.S. is the economic imperative that surrounds that. And we're going to have to work that out. I mean, we certainly don't want small communities, et cetera, to lose their local hospital. And we need to think about payment and reimbursement that keeps those hospitals functioning to offer the services that they should be offering. But, everybody on the corner shouldn't be opening up a PCI and CABG center because it's driven by the economic imperative. I was in Chicago recently visiting one of the major hospitals there, and they told me that there were more than 50 open heart programs in the immediate Chicago area. Is that really necessary? I think those are the kind of things, now that we've got sort of through the first hurdle of health reform, we need to really start thinking about the details. And I actually would favor specialized centers for complex diseases, not just cardiac ones, but complex diseases in general.
I agree. So it sounds like there's still some work to do. Bob, thanks again for spending some time with us. My guest faculty today has been Bob Harrington, one of my colleagues here at Duke. Bob's a terrific discussion, and look forward to seeing it on the web. Thanks again.
Thanks, Sunil.
Until next time, then, from all of us here at Duke, this is Sunil Rao saying thanks for joining us and take care.